right. Good evening, everyone. Nice having everyone here talking about neuroendocrine tumors. And my part of the session will be mostly informational about background. So many of you may be already experts in neuroendocrine tumors, so I apologize if it becomes repetitive or it becomes too basic for you, but I want to make sure that for all the audiences, we have enough information to discuss the next steps and the next speaker. So I set the background for them. So as many of you know, neuroendocrine tumors have been a part of the cancer spectrum for many years. Some of them are actually just learning about these diseases, but they had been described in the literature since at least the 1907 when the first description of carcinoid was made. And a number of developments have happened since then, as you can notice in this slide here, all the way to 2018 to the latest approval of Lutathera. But there's a number of developments that have happened throughout the latest years, actually. As you can see, from 1907 until 2002, until we found that there were somatostatin receptors in those cancers, the developments were very slow. But now we're getting more and more approvals and better treatment options for our patients, so which is great. So an introduction for neuroendocrine tumors. Neuroendocrine cells are ubiquitous. That means they're everywhere in our bodies. They are neoplasms, epithelial, that they have a predominant neuroendocrine differentiation. That means they have a component of endocrine component, secretory, and they have a neural origin as well. In the past, they were considered benign tumors, but now we know that they're not, that all of them have malignant potential. They metastasize. Some people say, you know, these are actually very rare tumors. Why do I even care about them? But actually, the gastroenteropancreatic neuroendocrine tumors, their incidence and prevalence is higher than most GI cancers, including pancreas, gastric, esophageal, and liver cancers. The only exception to this is colorectal cancer, which we know is the third most common cancer in the United States. The most common sites of origin are the GI tract, followed by the lungs and the pancreas, at least in the Western world. In the Middle East and Asia, there's a little bit of a difference in prevalence when we notice that the pancreas is the one that takes the lead in that specific population of patients for different reasons. And neuroendocrine tumors is really a diverse group of many malignancies that in the past they were put in different buckets, and hence that led to people to believe that they were rare. But if we put them all together based on histology and the way they behave, there's a lot of them, and you may recognize many of these names here: gastrointestinal NETs, PNETs, multiple endocrine neoplasia type 1 and 2, medullary thyroid carcinoma, pheochromocytoma and paraganglioma, poorly differentiated small cell or atypical lung carcinoma, small cell cancer of the lung, Merkel cell carcinoma, and adrenal tumors are all considered neuroendocrine tumors. How do they appear? There's a really poorly understood natural history for these malignancies, but in some of these instances, it's because of genetic alterations. Between 2 and 40% of neuroendocrine tumors, there's a mutation in MEN1. For most tumors, there's no real causation that is evident. The only exception is type 1 gastric carcinoids or neuroendocrine tumors, which are related to low acid states and pernicious anemia. In 2010, there was a change in the way we looked at the classification of these tumors. So in the past, we used to call them the foregut, the midgut, and the hindgut, which you can see here, the organs that we were associating them with. But the WHO, the World Health Organization, changed the classification for a more formal one, which I will describe in a minute. So before I go to that, I wanted to clarify a little bit between the differences between neuroendocrine tumors and carcinoid. So carcinoid is a term that was coined in 1907 when the first description of these tumors happened. And they typically imply that a tumor is benign. That's what some people didn't even care about these tumors before. But as we're learning further, we know that all these cancers are malignant. They can metastasize. And as such, we are transitioning, at least in the academic centers and the others, when we're getting more and more of these cases, we call carcinoid tumors when the tumors are producing, are functional, making a carcinoid syndrome, which we'll speak about it in a minute. But overall, we want to call them neuroendocrine tumors so people understand where they're coming from and classify them better. So how do we classify these tumors? There's different kinds of classifications that we take care of. One of them is the site, so we think about intestine, pancreas versus others based on frequency. The classification based on behavior. So a couple of them is grade. So grade is the inherent biological aggressiveness of the tumor itself. And this is measured based on Ki67, which is a stain that looks at the nuclei of the cells and see how many of them actively dividing. And the same by looking at the mitotic count by looking at the fields and see how many of those cells are staining for multiplication, for duplication. It's prognostic and it's independent of stage. So you can have a stage 1 very localized tumor and still be very aggressive. On the other hand is the stage, which is the extension of the cancer within the body. And that's based on AJCC, ENETS classifications, and is prognostic and also independent of the tumor grade. Natural history of these tumors, particularly in the GI tract, it could be many years since actually you have the origin of the tumor appearing until the tumor metastasizes to the liver and it starts to produce symptoms such as carcinoid syndrome. So it may be up to 9 years when natural history of these tumors appear, and that is important because we need to start to detect these tumors earlier, or at least detect them in a way that we can cure them. Just a little about carcinoid syndrome. Carcinoid syndrome is a syndrome associated with the tumor being metastasized to the liver. It's comprised of flushing, diarrhea, heart valve lesions, cramping. The only exception to the carcinoid syndrome is the case of bronchial carcinoids, which are carcinoids that originate from the lungs. Because they bypass the liver, they have a completely different presentation. So they could have flushing, diaphoresis, they have lacrimation, salivation, and edema. So a little bit different from what we know already on other tumors. So this is the WHO classification here. That, as you can notice, is based on mostly the grading here, low grade, intermediate grade, and high grade, and is based on mitotic count and Ki67. So the gastroenteropancreatic neuroendocrine tumors, the magic numbers is 2 and 20, so less than 2, between 2 and 20, and more than 20. That's how we classify them. In the lung and thymus is 2 to 10. Those are the numbers to remember. And anything that is between low and intermediate, that's what we call the better prognosis types. When you have a high grade, more than 20%, when you know that this is a very aggressive tumor that needs systemic treatment. And we also classify them based on functional versus non-functional. Functional, if they produce a substance, a hormone that may manifest as a syndrome, particularly in pancreatic neuroendocrine tumors. And the grading has a major prognosis factor that has been detected. This is an ENETS grading proposal, where you can notice here that the grade 1s have a significant survival compared to the grade 3. You can see that curve cannot be in a curve, it's more like going down immediately. And it is all dependent on the stage, on the grade, I mean, not the stage. Pancreatic neuroendocrine tumors, these are the substances that we talk about. So there's many of them. Gastrinoma, insulinoma, glucagonoma, bipoma, somatostatinoma, and PPoma. All of them are dependent on the kind of islet cell type that is involved and the substance that they predominantly produce. The relative frequency is most patients are asymptomatic, followed by insulinoma, which are the ones that patients will present with hypoglycemia all of a sudden, regardless of the type of the size of the tumor. It could be a very tiny tumor, but if it does enough insulin, the patient becomes hypoglycemic. Gastrinoma and glucagonoma are the following ones. And there's an extensive diagnostic biomarker matrix that we follow for each one of these patients with its correlatives on the symptom size that is here for your reference. And just to give you an example, one of these cancers, glucagonoma can present just by this phenomenon called the necrolytic migratory erythema, which is a very pathognomonic. That means that only patients who have this cancer and have the glucagonoma will present with this syndrome. So how do we stage these patients? The staging of these patients follows very standard as we do for many cancers. That includes multiphasic CT scan or MRI based on location. As we're learning more and more how these tumors are behaving and the specific theranostics involved, we are also moving forward in doing more scintigraphy or somatostatin specific. So gallium scans, and in the past we used octreotide scans. We're moving now to the gallium-68 scan because of its increased sensitivity and specificity. And this is manifested here by a meta-analysis of 16 studies comprising over 600 patients almost, when the pool sensitivity and specificity of gallium-68 scan was about 93% to detect neuroendocrine tumors. So this is a pretty good test for our patients, and as we're going to learn further on this session, it's also not only able to detect the cancer, but also to predict responses to certain therapies, including PRRT. And this leads to this image here that shows us the theranostic discussion we're going to have today. So this is the dotatate molecule here, where we're noticing the two components. So the blue one is the DOTA, and the tate is just the molecule itself that attaches to the somatostatin receptors. And if you attach it to the gallium-68, it gives you a diagnosis. And if you attach the same to the same molecule, lutetium, which is another component here, that will give us treatment. So that's what we call the theranostic, because we're able to do not only diagnosis but also therapeutics just by looking at the dotatate molecule. And just to give you an example, because we're going to have plenty more on the session, some people just call it a PET, like, oh, I'm going to get a PET. And this is completely different because the regular PET that we use is attached to fluorodeoxyglucose, which is whatever captures more blood sugar because of increased metabolism. We'll show in a regular PET, the FDG that we call. But as we're learning more about the gallium dotatate, that attaches specifically to somatostatin receptors and may have also a relationship with the grade. So here we have the same patient with a PET scan, FDG PET on the left side, and then a gallium scan on the right-hand side, and we can see that depending on where you put the needle based on the images, you're going to have different grades of aggressiveness on the tumor. And it speaks about the heterogeneity of these cancers as well. Sometimes we call it evolution of the neuroendocrine tumor, but sometimes it may not be that. It may be that actually we are putting the needle in the most aggressive or more indolent component of the cancer at the time. So what are the treatment options for these patients? So it all depends on the stage, how extensive the cancer is, and the grade. So we know already if it's a very aggressive, more than 20% grade, then systemic treatment is the way to go for many of these patients. Surgery can happen in some cases, but it's not recommended. We want to be aggressive because we want these patients to avoid any disease progression. When the disease is local, that we can resect it and it's a low grade, if it's resectable, we resect it. If it's metastatic, we can choose either observation or we can try to use somatostatin analogs, because many of these cancers are going to have that receptor, and because of some information I'll show in a minute, we know we can prevent progression in those cases. So what are the treatment options? Surgery, debulking, we have radiofrequency ablation, liver-directed techniques such as embolization, chemoembolization, radioembolization, which is yttrium-19 transanterior radioembolization. We have the systemic options for advanced cancers, which include the somatostatin analogs such as octreotide LAR or lanreotide. We also have targeted molecular therapies, which include Sunitinib and everolimus and other TKIs, and we have radiation treatment, which we're about to talk later in the session, including the Lutathera. So why this is important? Because we're using targeted therapies in a lot of these in all of these neuroendocrine tumors. Because of the presence of the somatostatin receptor, we can attack these cancers in a more targeted way. Instead of using the atomic bomb example, we're using the sniper approach that is going to lead to better outcomes, hopefully, for our patients. So the somatostatin signaling, it's one of the most important findings in neuroendocrine tumors. We know that these receptors are expressed in about 80% of all neuroendocrine tumors, regardless of the site of origin. And the overexpression is what provided the basis for all the treatments that we offer to our patients. Octreotide can have, which is basically the inhibition with somatostatin analogs, including octreotide and lanreotide. It has a direct anti-tumor effect and can also prevent the tumor from progressing, and it leads to a number of benefits in PFS and time to progression, as we'll describe in a minute. The first one is the study, the PROMIT study, which was the first medication that we had that targeted this receptor that used octreotide LAR, 30 milligrams once a month, compared to placebo. And we saw that regardless of the functional status of the tumors, and even the presence or not of octreotide positive disease on the scintigraphy, we actually had those responses in a way that the patient had decreased time to progression was improved in the treatment arm compared to placebo. The other somatostatin analog that we use is lanreotide. This is based on the Carcinoid study, where it, in this case, was used in non-functional gastroenteropancreatic neuroendocrine tumors. They compared to placebo as well, lanreotide and autogel 120 milligrams every 4 weeks. We saw a progression-free survival in the intent to treat population, which was meaningful and led to the approval. There was more data coming later from the ELECT trial that showed that in patients with carcinoid syndrome, they also benefited from the use of lanreotide. So that's the other indication in approval by the FDA. And sometimes we think, okay, this is just not making much of a difference in our patients, but actually it does. This is data from the Carcinoid study called the tumor growth rate. And we know that when we measure tumor growth rate, we can detect very early that we are actually stopping the cancer growth by using the somatostatin analogs. Then the next line of treatment is the mTOR inhibitors, such as everolimus, which is another treatment that is used in neuroendocrine tumors. Alterations in the mTOR pathway may result in development of some NETs, and that's what led to its implementation in patients like this. In some cases, patients get treatment with somatostatin analogs and everolimus, and it has a combination potential benefit based on phase 2 data. And lastly, the data from the RADIANT tree, which is the everolimus 10 milligrams per day plus best supportive care versus placebo, led to the benefit of this drug in neuroendocrine tumor patients. It produced 65% reduction in progression compared to placebo, 4.6 months versus 11 months. And that's the rationale for our patients also being treated with this drug. And lastly, we have Sunitinib, which is a tyrosine kinase inhibitor that has some reported benefit on PFS that unfortunately wasn't put together to the test in a larger study because of different accruals, but overall, we see some potential benefits. So in some patients, we try these drugs as well. This is a small summary of all these. There's no way to compare head-to-head different treatment options, but we use them all in appropriate sequence. There's no specific sequence that we have determined as per consensus, but we know that if we can do somatostatin analogs up front, we do it as part of the expectant management of the patient, and then we move on to the next line of treatments depending on that. The other things that we use is chemo. So chemotherapy, one of them that is very well described is capecitabine and temozolomide. This is the data from Dr. Fine, where phase 2 trial, 28 patients with metastatic well-differentiated neuroendocrine tumor were given, who had progression only on sandostatin LAR. They were treated with CAPITEM, and the response rate was 43%, the stable disease rate was 54%, and ongoing PFS was more than 20 months compared to historical data from everolimus and Sunitinib, and as such, we still use it, and it's part of the guidelines in NCCN. This is a patient of mine who was treated with CAPITEM and atrium-90 radioembolization, and the patient almost had a complete response. I mean, we see a lot of ex-vivo changes and necrosis, but overall, the patient had a very good tolerability and response that we can use. And that leads to the next step, which is PRRT, which I will not delve too much into it because we have plenty of speakers for that. But it was approved, and that led to a new exciting era for us to start using this agent in our management of neuroendocrine patients based on the NETTER-1 results that will be described also as well. But we see now that the PFS in the Lutathera arm was more than 40 months, which is absolutely impressive and something that many of our patients now are looking for. So without further ado, I think we're almost done in our presentation. These are the NCCN guidelines. So they basically summarize all the options that I just mentioned here, including lanreotide, octreotide, everolimus. PRRT actually is included as well in the guidelines, and this is the version 2 in 2018. And the good thing is that actually was selected for all kinds of neuroendocrine tumors, so they stopped putting patients in buckets. they now are actually allowing patients to, if they have neuroendocrine tumors, to have access to this medication, this treatment. So what's the future? The future maybe will be combining with other things, including chemotherapy. So this is the peptide receptor radionuclide therapy, or PRCRT, which is basically using chemo along with PRRT. There's some data already presented in other forums where we see some potential benefits, and that's now to be tested. This is just a case study of those patients who had good responses to treatment. So there's a couple of clinical trials. The first one is the Control-NETS trial, which is currently in Australia. It's basically Lutathera treatment, what you will know, compared to capecitabine and temozolomide versus the combination arms. So it's a very interesting study because we're going to see the responses across different arms, and we're going to make some conclusions, hopefully, based on this. And the Occlu random trial, where they're comparing actually PRRT treatment with Sunitinib as part of the treatment option as well. So, and last but not least, it's maybe we're going to start using oncolytic viruses and other treatments. So there's a RADNet trial where we're not using, I mean, I'm not using, but they're using it, recombinant adenovirus in patients with neuroendocrine tumors, and this is very exciting as well. So the future perspectives, timing of PRRT within the treatment paradigm, assessing prospective differences between lutetium and yttrium, because I know there's some questions still based on data that was developed in Europe compared to the ones in the United States based on the NETR studies. The use of tumor growth rate plus the gallium scans to assess responses to PRRT will be of interest. Combination of therapies with capecitabine, temozolomide, and other treatments will be interested, including immune therapy. Maybe we're going to find abscopal effect in some of these patients if we use some form of immune therapy along with PRRT. And expansion beyond gastroenteropancreatic neuroendocrine tumors, which luckily enough we are seeing now as the guidelines are including all kinds of neuroendocrine tumors in the treatment paradigm. So in conclusion, we as medical oncologists need a lot of help to make this a multidisciplinary approach and helping patients to get access to the best treatment options. The overexpression of somatostatin receptors have enabled theranostic approaches in these patients that are adding to the current options, including somatostatin analogs, TKIs, and chemotherapy. The gallium scan is now offering utility for diagnosis, prognosis, assessment of therapeutic response, and long-term follow-up, and should become the standard of care imaging based on our perspective. The Lutathera PRRT has efficacy and short-term safety and could be considered for advanced neuroendocrine patients that express the somatostatin receptors and are otherwise refractory to treatment. And future studies should focus on combinations of this treatment to improve treatment options in the treatment paradigm. Thank you.